But it comes now, let's say that we have a patient with hepatocellular carcinoma, and Adam, I'll turn to you. I know surgeons have their hands on it. Tell us, cirrhosis, non-cirrhosis, how do the liver look like?
Well, it's funny, it's a little bit different on the Upper East Side of New York, but I don't see the non-cirrhotic patient. Most of the patients that we're seeing down in Texas have the hepatitis C, about 80%. And so essentially, the livers that we see are all cobblestoned. And I think even nationwide, most of the patients that we do see with HCC are cirrhotic. And it becomes a little bit of a challenge. We're trying to decide whether to operate or not operate on these patients or offer some sort of essentially non-curative therapies. And what we have to try to balance is the underlying liver function as well as the tumor, what the tumor looks like. And essentially we do that a lot through these multidisciplinary forums, and I think I can't encourage that enough. I mean, that's essentially, we talk about every patient at that forum and make a decision.
It's fascinating what you say. Actually, we hear from our colleagues in Hong Kong where hepatitis B is most common, where truly they have more hands-on surgery because of the lack of cirrhosis among those patients with hepatitis B. And actually, on the educational component, which is critical, Hep B and Hep C are like nothing but two viruses standing at Starbucks one after the other. They got the B followed by the C. Tell us what is really different genetically.
So hepatitis B is a DNA virus, incurable. It inserts itself into the liver genome, and it's a pro-oncogenic virus, not just through inflammation or fibrosis or cirrhosis, but directly changing signaling in the liver cell. Hepatitis C is curable, like we talked about. You can take one pill a day in many cases for 12 weeks, and cure rates over 90%, a true cure. And it doesn't insert itself into the genome. It really causes cancer by inflammation and fibrosis.
It's RNA, correct?
RNA virus, lives in the cytoplasm, truly curable. So this is really, whales and cows. I mean, it's a completely, they're very different. They're both mammals, but they're living different lives.
That's why they're sat in sequence.
Can I just ask a question? Sure. Because one of the key issues is that patients always ask is the lifetime risk. Is there a difference between a patient who is chronically infected with Hep C and one who has, fatty liver and NASH cirrhosis? Do you know how long it takes for the cancer to develop and the lifetime risk of these patients to develop HCC?
So I can help with that a little bit. So in regard to Hep B, it's a risk of about 0.5%. In regard to Hep C, it's about 5%. And no question that, in other words, the risk is there and is potentially of concern. In regard to Hep B, it can develop early, even without any cirrhosis, as we heard just from Adam and Bob. In regard to Hep C, however, there's a certain developmental period to induce that inflammatory component that take from 10 to 30 years. So it's not really off the hook. And I think it brings back the key question that actually Richard asked in regard to what do we do with those patients who are cured of hepatitis C? How long do we screen them? We heard about the 5 years component in that regard. I'll come back to you, Jeff. Actually, I have another question because I'd like to go over the different disciplines, despite we didn't talk about therapy yet. But is the same thing, do you agree, like Adam, in regard to interventional radiology, how much of a challenge is the cirrhosis?
It is a challenge, but not as much as for surgery, for the simple reason that we don't cure the patients. We only palliate them, and I think that's the big difference. However, it limits our ability to intervene. There's no question about it. Although we'll talk about it later, probably the most significant determinant of whether we can intervene or not is really the performance status. But nonetheless, the cirrhosis and the degree of function of the liver is obviously a key component of our decision-making processes.
And from the medical oncology standpoint, one of the challenges, Richard, we see with our colleagues is sometimes they are seeing the cancer component, but please tell us, as a medical oncologist, how do you assess patient cirrhosis?
Well, this is really two diseases, right? And two competing risks for outcomes. There's the liver disease, and then there's the oncologic anatomic malignancy. And this will play into this idea of staging, which we'll probably talk about a little later. But unlike other malignancies, breast cancer, colon cancer, these other cancers we all treat, they're generally in healthy people with healthy organs, where in this case, 90% of the patients have some degree of liver dysfunction. And that always has to come into play when we decide what the appropriate treatments are. If someone has very bad liver disease, who is decompensated, has ascites, a high bilirubin, this is someone who, regardless of their tumor, we probably cannot impact their survival significantly. versus someone who's better compensated, who's up and about, a good performance status, Child-Pugh A cirrhosis. These are patients who we have a little more leeway and can impact their survival. One thing we shouldn't forget, and it relates to surgery, and the reason why we're screening patients is to find small tumors because this is a curable disease. And if not by resection, then certainly with liver transplant. And that becomes a huge modality in curing these patients with early disease.
Sure. And if anything, we'll summarize that part, is that cirrhosis plays a key critical component in the disease, especially in the United States, as we noticed because of the etiologies that we're seeing, mainly it's hepatitis C and NASH, as we just heard. And as such, kind of evaluating that cirrhosis will be a critical component for oncologists. As you noticed, we not necessarily did go in that detail of how do you evaluate it, but we heard from Dr. Finn, for example, you can use the Child-Pugh scoring system. This system that's relatively usable, friendly, it has certain limitations, but acceptable enough to kind of at least will be a reasonable effort to put into clinic in oncology, or part of the staging component that you do in regard to diagnosis and management. And let's assume